culmination of many years of work for that dissertation work, and I thought it was applicable because the idea for it started here at Geneva in 2015 in the Master's Counseling Program. So bear with me, I'm trying to make it brief, but my dissertation was over 1,000 pages, so I did a lot of condensing. Let me start with the background problem. Mental health care increasingly recognizes the need to incorporate spirituality, faith practices, sociocultural context into treatment. However, most case conceptualization models are theoretical, meaning they're tied to one type of treatment theory, and do not include spirituality and faith practices. This leads to fragmented client formulations and limited treatment options and reduced clinical effectiveness. I developed HCCM, the Holos Case Conceptualization Model, as an intersectional, atheoretical model which centers on the client's voice and their lived narratives. It embeds spirituality, faith practices, cultural, sexual, and gender identities, along with race, class, biological, psychological factors, and how all of these factors intersect to make the whole person and whole case conceptualization. I used a mixed method interpretive phenomenological analysis, and my data sources included therapy transcripts, client journals, interviews and assessments, my own progress notes as a clinician, and semi-structured pre- and post-treatment interviews. There's a significance for this. The Holos case conceptualization model provides a holistic framework for how we proceed with mental health treatment. It strengthens the therapeutic alliance and it improves treatment, engagement, and outcomes. It supports culturally responsive and spiritually integrated care. And it goes a step beyond being culturally informed to having a cultural humility. The implications for this educationally is it supplies new clinicians for a manual and a framework with which to provide treatment. Oftentimes, I have guest lectured in the counseling program here, and I hear students say, I know that I'm supposed to do all of this, but how do I do it? It supports multicultural and spiritual competencies, and once again, I will say this, humility. It aligns with ethical guidelines from counseling, social work, psychology, and psychiatry organizations. Previous research informs us that case conceptualization organizes client information and it guides strategies, especially when you have complex treatment cases. Modern scholarship emphasizes holistic understanding of our clients within systems of race, class, culture, gender, sexuality, and spirituality. This intersectional approach challenges older monocultural frameworks. It encourages holistic assessment and structural awareness. It promotes a collaborative meaning-making formulation with clients as opposed to being prescriptive. It's co-constructed. And it supports, and it's culturally responsive and social just care. This is a picture of me in this very room. It's a little blurry. In 2017, being inducted into the Chi Sigma Iota International Honor Society of Counseling. And so I thought it was fitting that here I am in 2026 presenting on the culmination of the work. The interpretive phenomenological analysis focuses on the lived experiences of the clients that I worked with. It's an idiographic case-by-case analysis with a double hermeneutic as me as the client or the clinician and the researcher interpreting my clients' not only mental health, but their lived experience and their meanings. So I very often had to make sure that I was framing myself as both the clinician and the researcher, and them as both the participant and the client. So I did reflexive journaling myself, and I also engaged in clinical supervision throughout the study so that I made sure that my clients' observations were being checked by a clinical supervisor for myself. And I bracketed my assumptions throughout the analysis. I used a purposeful convenience sampling, and because I wanted to have a depth in meaning versus a breadth, I limited to 10 adults, and they recruited through a church that I was providing psychoeducational sessions on mental health in the Bible. And the criteria for that were that clients, participants, wanted to seek mental health and that they were adults. Okay, I accepted no couples, no family therapy, and no children. Once again, I audio recorded therapy sessions, I had semi-structured interviews, my clinical notes, and I triangulated multiple data sources. Informed consents for voluntary participation, pseudonyms were used, and I made sure that all the guidelines by ACA and APA were met. I had 8 participants. Their mean age was 57.6. 6 were female, 2 were man, all cisgender and heterosexual. 7 were Christian and 1 was Jewish. Their presenting clinical concerns were anxiety, depression, PTSD, trauma symptoms, substance use disorders in remission, personality disorders, and a huge amount of relational distress and identity concerns. How this compares to national statistics, my sample was slightly older than the average treatment population. The female participation was consistent with national standards. There was a higher divorce rate in my sampling than national averages, and a higher Christian faith representation, although I'm sure that had to do with my sampling from a church. My IPA data analysis approach was idiographic and case-by-case analysis, repeated transcription reading, detailed note-taking, emergent theme development, and cross-thematic synthesis. I skipped, for the sake of time, the individual analysis of each client participant, and I skipped to the superordinate themes. Identity formation and self-understanding were one theme, trauma, loss, relational wounds, spirituality and faith practices and treatment, boundaries, autonomy and agency, cognitive and emotional regulation, therapeutic relationship as a corrective experience, and socioeconomic and environmental stressors. Many of my client participants struggled with the concept of self and their own self-worth, their spiritual identity and meaning-making, cognitive distortions affecting their self-perceptions, and interventions included journaling, cognitive restructuring, and theological reframing. Many of my clients and participants experienced trauma, loss, and relational wounds. They had histories of abuse, betrayal, and grief, post-traumatic stress symptoms, relational disruptions and attachment injuries, and their past trauma related to their present functioning. Spirituality and faith practices was a theme throughout all of my clients' work. And faith as an interpretation lens for suffering and healing was instrumental. Spiritual practices which they engaged was prayer and scriptural reflection. Integration of faith in the therapeutic meaning making was extremely helpful for them, and support for identity reconstruction and resilience. One client expressed that she was able to see herself as a child of God through therapy, which she didn't deem herself worthy beforehand. Many of my clients had difficulty with boundaries, autonomy, and their own agency, dependency and relational overfunctioning, difficulty asserting their own needs, therapeutic focus on boundary development, and an emergence of personal agency. They often experienced cognitive and emotional dysregulation in the form of black and white thinking and rumination, shame-based internal narratives. CBT strategies and thought restructuring helped with this and resulted in improved emotional regulation and insight into themselves. The therapeutic relationship was an alliance and a mechanism for their change. Participants reported feeling heard and validated using this model. It was a corrective emotional experience, and they felt that the experience was collaborative and therapeutically engaging. Socioeconomic and environmental stressors, and in this economy, who doesn't feel some of that? So they experience financial strain and occupational dissatisfaction, health limitations and caregiving responsibilities, structural stress influencing their mental health, and contextual integration with the HCCM model. Those were the superordinate themes. These are some of the sub-themes identified: grief and unresolved loss, dependency and relational enmeshment, cognitive distortions and misdiagnoses by previous therapists, empowerment in spirituality reframing, and the value of being heard. Who doesn't want to be heard? Layered losses and grief, bereavement, and relational rupture. Grief not necessarily meaning death, but the grief of relationships, the grief of losing a childhood. Identity and grief because of abuse and neglect they suffered. This connected to trauma and substance misuse. And it also often connected with their spiritual identity and dimensions of mourning. Not unlike what you were talking about earlier. They often experience dependency or codependency and relational enmeshment, enabling and from those that they loved, enabling poor behaviors, and had difficulty setting boundaries. They were relationally vulnerable, and they had reduced autonomy because of this abuse and neglect. They often experienced rigid thinking patterns, shame-based self-labeling, and diagnostic clarification helped support their insight. Increased assertiveness and empowerment and the reconstruction of self-worth was integral whenever you were incorporating spirituality and spiritual reframing, and the integration of faith and psychological growth was instrumental in that. Participants in their post-treatment interviews emphasized validation and listening, and the corrective relationship experience with me as their clinician and also the researcher. They had an increase in therapeutic trust because of the value of being heard. This has significant clinical implications because it incorporates intersectional identities, race, class, gender, sexuality, spirituality, and promotes cultural responsiveness and interventions. It does nothing but strengthen the relational engagement and the therapeutic understanding of our clients. Prior to this, we only had what was called the biopsychosocial model, and it left out all of these other elements. The HCCM functions as a pedagogical framework for teaching case conceptualization. It provides structured scaffolding for novice clinicians. It encourages reflective and integrative clinical practice. There's some limits to my research study. It was a qualitative design method, so it emphasizes depth rather than being able to generalize the results. My sample may have not represented all client or faith-based context, and my researcher positionality may have influenced the interpretation of the results. I would suggest in future research that there is more empirical testing done of the model that I created, that cross-cultural applications and longitudinal outcomes be assessed. I was limited. I didn't want to stay in my doctoral program indefinitely. So I limited my research to 6 months, where some of the personality disorders that I was treating, the people with personality disorders I was treating would have benefited from much longer therapy relationship. And this should be considered into integration to clinical training and interdisciplinary studies. My final conclusion is the HCCM offers a promising framework for holistic case conceptualization. It supports integrative and clinical practice in faith-sensitive care, and it contributes to contemporary counseling and even pastoral care research. That's it. How did I do?
You're good for time. We're actually early, so.
I started out with over 100 slides, and I condensed that down.